So I hope you're all going to enjoy. I think we've got 4 updates for you today on different projects. So let's just do the preamble slides. If we can move the next slide on, please. Oh, sorry, just to clarify, we are recording, and please through the conversation, if you want to use the chat to make a comment or ask a question, please do, and we'll come to questions at the end of each presentation. So just a reminder, People First programme, trying to do 3 things: generate real clear respect for staff by involving them in improvement, really make sure we focus on value in terms of patient care, value towards patients and patient care, and helping teams drive improvement. And it nearly always means sharing their brilliant ideas around the trust. Next slide, please. Some of the pillars of our practice, and I think you'll see some of these being used today. So clear purpose, being able to do a plan, do, study, act, and measured test of change using really clear metrics, huddling as a team and using the power of teams to make move on, and looking after teams in terms of team health. Let's move on to the next slide, please. So we've got 4 really interesting presentations, all different. So I think Laura's going to kick us off in a second, but we've also got the start of work in R&D. Matt Lamerton, I think, is doing his CATA presentation, and Burrator, Tara on Burrator is also doing a presentation. So you're very welcome, Tara. Sorry you're last, but we'll get to you quite quickly. So I'd just like to hand over to Laura if you're there.
I am here, but I'm really snotty, so I'm not going to turn my camera on if that's okay, because I look horrendous.
We all feel for you, Laura.
Thank you. So my problem that I've been working on is about achieving early admissions into Mount Gold. So I started my People First programme quite early on in my journey within UHP, and I quickly identified that there was a lag between when patients were being discharged from Derriford and when they were being admitted into the wards at Mount Gold, and that we had a capacity that we could utilise earlier for those patients. So it was around the patient journey initially, around it being better for the patient arriving earlier on during the day. Their families would be able to see them, they'd be able to move during daylight hours rather than of an evening. And then secondly, it was also highlighted as a contributory factor with an RCA. So it was quite a significant incident on our ward where a patient had choked. The patient had arrived out of hours, and it was felt that because they had arrived at that time, there wasn't the capacity within the nursing team to be able to do a full review of the speech and language assessment, and therefore they missed a critical piece of information about modified diet. So it was kind of threefold. It was about flow and meeting the needs of the system, secondly around better patient experience, and thirdly around patient safety. So when we did our initial review, anecdotally we were being told that they were always coming late, but we reviewed it specifically for 3 weeks, and during that period there were no admissions pre-noon achieved on any of the wards. So that was my kind of problem that I started on. So can I go to my next slide, please? So we used multiple approaches. The first one was around process mapping, where we engaged with multiple partner teams internally within the organisation, and kind of partner agencies as well, to work out what the patient journey was in terms of actually getting from Derriford down to one of the Mount Gold wards. As you can see, it was quite complex, and we did the analysis of it, which gave us a 46% yield and only a 20% process efficiency. So actually there were lots of steps within the process that added no value to the patient as well. Next slide, please. So from that process, we tried to find some data around trying to understand what the actual position was. When we started looking at it, the top graph on the left hand side is the system's analysis of what was happening through Salus. The team at that point were quite new to using Salus, and what Salus was showing us was not reflecting what the team were reporting locally. We were seeing that there would be long periods of the bed being empty, but we knew patients were actually in those beds at those times. And then we were also seeing information that patients were being admitted earlier in the day. What that correlated to in terms of the process was the patient was coming down late. They weren't being admitted into the bed space on Salus. So the bed space was showing us emptier for longer, but then they looked like they were being admitted really early in the morning, and it was a positive thing, but it wasn't. They were actually arriving late in the evening, but weren't showing in the bed space till the morning. So once we'd unpicked that slightly, we decided we'd go on a localized data collection, and that is what you can see in the right-hand corner at the bottom. So again, it was very crude, and it relied upon staff engaging and completing it. But because we wanted to get moving with things, that was kind of the way that we agreed we'd do it. And we kept that same process throughout the whole time to enable us to have that kind of comparability between the data sets. Can I go on to the next slide, please? So we also did a fishbone, or I did a fishbone, and I split it out into areas that came up as key aspects, probably drawn from the process mapping that you saw earlier on. So one was significantly around myths. Sorry, I just spotted a typo there, sorry. That patients couldn't be admitted to their community hospitals until after 3 p.m. That was quite a strong one that came out, and we don't know where it came from, but it was definitely something that people within Derriford were adhering to. And also there was a belief within Mount Gold itself that they couldn't complete their discharges until later in the afternoon because the community weren't ready to accept those patients either. So we unpicked those and started to dispel them. We then started to look through more complex areas of the process, which proved slightly harder to unpick. So this was about obtaining handovers, the doctor review being completed within Derriford prior to the patient being transferred. The TTA process, as we know, is complex for every patient that's coming out of Derriford, but it felt like there was an opportunity there. And then also around the time that the transport was being booked, and when the transport was being booked for the patients. The next factors was around systems and understanding. So just for context, at the point that we started to do this, so at the point that Salus started to being used was just after Mount Gold had 2P'd across from Livewell to UHP. So understanding the systems and the requirements of reporting within UHP was quite new to the wards at those times. And there was also, we also identified that there was a lot of toing and froing trying to transfer and share information within Command Centre that kind of generated a whole industry of work that didn't need to be there if we were just transferring information correctly. Initially with the fishbone, we wanted to, it seemed quite overwhelming. So initially we really focused on dispelling the myth aspect of it, because that really did feel within our control and something like we could get on top of. And then we tried to work through the processes more succinctly. So the obtaining handovers was a key one for us. There was a lot of toing and froing between nurses in Mount Gold trying to access information at Derriford and backwards and forwards again. So we put in a different process around that. The TTA one we did try and explore, and we are still trying to explore, but the medication is managed over 2 different organisations, and there's different organisational needs associated with the TTA process, which we're still trying to get to the bottom of. The Salus one was quite easy. We could do an education programme within the hospital, in the community hospitals, and we also had Salus screens installed on the wards so that they were more meaningful. The information was more meaningful to the wards, and that has become a lot better and is really good now. And then also that there teams were using old processes around booking transport, so we moved them onto the electronic transport booking system, and that was quite easy as well in terms of a quick win for us. So we tried to pick off the easy small level stuff and kept the higher level stuff in mind, but mindful that it was kind of, we needed to pick off the low-lying fruit that we could actually make a difference with in terms of what was within our sphere of control. So next slide, please. This is the data. So just to refresh where we were at the beginning, there were no admissions pre-12 o'clock when we started. The first data set, as you can see, goes back quite a long way. I have to put my hand up. I have probably been the longest person on Practice Coach in the world. I apologise, Richard. So the first set of data, I had transferred it into percentages because I felt that that might be an easier way to demonstrate the trends, and would give us an analysis, because we don't have a static admissions rate, so there was variation throughout the week, but actually what it was doing was hiding some of the data. So when I've reinvigorated things. We've looked at recording things in the actual numbers achieved. So there is still significant variation. Key things that I can note and can explain some of the variation, specifically within the blue line on the bottom, which is the before 12 one, are external events. By that I mean things like junior doctor strikes or critical incidents. When either of those happen, things go really wonky and our discharges move towards later in the day. But I think the performance in terms of the orange line is really good. So actually that's the 12 to 5 o'clock line. So they're still coming earlier than where they were before. The fluctuation in the post 5 o'clock one, I think this is associated with, at the moment, we are very good at pulling patients, but as patients turn non-med fit, we're sometimes pulling them on the same day. When we pull them on the same day, there's the whole industry that has to happen before that in terms of TTAs and transport. So that pushes that activity later in the day anyhow, because we're no longer in a position to be able to pull 24 to 48 hours in advance. Next slide, please. So just as a overall outcome, so where we are at now is on average we achieve 2.4 admissions per week before noon, and we achieve 6.5 admissions before 5 each week, well, between 12 and 5. So really positive impact of where we were previously from being at that 0 before 12 o'clock. As I've mentioned there already, we've some of the external factors that influence us are around the junior doctor strikes, the internal critical incidents. High flow out of Mount Gold has meant that there's no longer a waiting list for us to pull from, and pulling the same day when patients turn non-med fit within the acute has quite an impact upon us as well. Have I got another slide, or I can't remember? Oh, there we go, yeah. Impact on staff and patients. So the early admissions has been that there's more opportunity to resolve things if there's issues with transfers. So TTAs can be chased and we can get them down via the courier service. Tasks associated with the admissions are completed by the appropriate member of staff. So e.g. like a ward clerk, as opposed to a nurse having to take something on overnight. Patients can arrive at more appropriate times, so they can have meals on their wards. Families can visit on the day of the move. Patients are feeling more supported by the process, as are staff as well. Patients are at less risk as there's more staff available during that period when they initially turn up, and they're also being admitted during a period when there is actually a doctor available, as opposed to just an on-call doctor system. I think that's it. Oh, no, it's not. Keep surprising myself. So my next step would be around trying to standardise the flow within the week. So at the moment, our activity definitely varies. Mondays are quieter, so are Tuesdays, in line with what you feel within the acute, and then our pressure ramps up towards the weekend, our discharges ramp up towards the weekend, and we can find ourselves in a position where we're going into the weekend with less support staff and empty beds, so it's difficult for us to source and pull over the weekend. Continued development within the pathway with additional organisational support. So TTAs is something that's being reviewed with the support of CANDARP at the moment, in terms of how do we change that going forward. I'd like to build closer links with the admitting wards, so linking our Band 4 member of staff who works within Derriford into our main admitting wards, and also to understand their processes as well, because we definitely see peaks in terms of their referrals to us. So is that related to when they're doing their MDTs and their ward rounds, etc., and lots of high patients turning medically fit, and what does that look like? So to understand that bit more, and then an electronic referral system that allows us not to have to do this ping pong of information, so we can actually see it in one place rather than having to go forward and backward on the telephone. And I definitely think that's it now. There we go.
So well done, Laura. Really well done. I think you've got some nice compliments. I think there was a question in there as well.
Oh, I didn't see. Sorry.
So it's fine. I'm going to bring you back to it in a minute. I think it was such a great presentation in terms of skills and tools used. So really well done, and perseverance. By the way, you're not the longest on Practice Coach. It's okay.
Oh, yes. Sorry.
But really well done.
Chasing me. Sorry, Richard. Yeah. I do know.
Hey, but great project. I think you've answered my question, which was going to be what happens next with this work. Is someone else, because you've got a bigger portfolio now, is someone else carrying on with this work, or is there any other support?
I think one thing that I didn't mention was one of the outputs of it was that we found some admin monies, and we collaborated those monies into new roles that better met our need in terms of how we support the system. So I think I will pass it on to those cohort of people to kind of take control of. So we've got a band 5 bed manager, we've got Cora based up at Derriford now, who's a band 4 puller, and I think if the support for them through the programme would be really helpful in terms of keeping it going and understanding how we take it to the next level. They've really got the autonomy around the practice now, as opposed to it sitting with me, so I think they're the best persons kind of to deliver that next best change.
Yeah, so well done, Laura. I'll kind of just direct you, so I'm not going to deal with it across the speak to it, but if you could look at Craig's question and maybe answer that, that'd be fantastic. Not now, but in the chat, that'd be great.
Yes, okay.
But really well done, and we're going to move on to our next presenter, which is, if Matt helped me out with the first slides, I've forgotten the order. Oh, Catherine, I hope you're there, and you're going to talk about some of the work in R&D.
Yes, I am. Thank you so much for asking me along to do this. My name is Catherine Pittman. I'm the lead research nurse here at Research and Development, and I'm going to talk a little bit about the People First programme that we have been working with Neil, Richard and the team. Next slide, please. So this launched on the 1st of November. And I am reliably informed by Neil that this is the next stage of the Corporate People First programme, which I believe has been implemented successfully in cancer services. Just a little bit about us. We are a fairly big department. We've got clinical staff and administrative teams. We are numbering well over 80 colleagues, and we all managed to squash ourselves in with them into that nice big office. And basically, we really started to vision how good we can be in R&D. And I think, anecdotally, everybody really enjoyed that session. Next slide, please. So this was really the idea of kicking off the session agenda. We all came together, we all mixed ourselves up. We didn't sit in our sort of little comfort blankets of our friendship groups or the teams that we normally work in. We deliberately sat with other people, and we basically set out the vision, which is our R&D medical director, Gary Minto, gave us that vision, which was really to champion research across the trust to really tackle health inequalities and improve the lives of patients. Each team was asked to support the delivery of this and what elements would make working in R&D every day good for them. So we spent a good couple of hours on all of this, and I have to say I admire Richard and Neil, the team, for keeping us all on task, because it's a lot of people to manage. So you did a brilliant job. Next slide, please. So through that work, we as a group, with the help of the Quality Academy team, identified some themes, and there was very nicely a good balance between internal and external opportunities, and these were distilled down to 3 of each, which you can see in front of you. These were the top 3 opportunities. We got to vote on them, so these were the ones that everybody felt were the most important, and obviously we are now moving forward into sort of the People First practice, which will assist some of these themes, you know, the purpose, the team huddles, the production metrics and all those conversations. But I think for me, one of the most powerful things I noticed around the room, which People First I thought was great at doing, was getting everybody to really listen to each other. Everybody fed back, and I think to me that was one of the most powerful things, and a lot of the things that people fed back to me, they really enjoyed that. Next slide, please. So this is what will happen now that we've actually kicked off the whole programme, and myself, Gary as our medical director and Corinna as our ops director will commence our senior team training at the end of this month. I think that's been an achievement in itself to get those dates set in. Well done, Neil. And the team leaders training is already started. I believe you've the second one today, so that's great. Yay, brilliant. And you know, they've taken the team leaders who are leading all these different teams across the department into improvement work, how we well, is that me or you? There's something that's come up.
Whoever's presenting the slides needs to cancel that. Thank you.
You can cut me off, I don't mind. But obviously we'll see some of these huddle boards and the improvement boards coming through now, which I'm quite excited to see. For me, I'm a great believer in this. I think it's great, and I think it gives structure for people. How do you do it? How do you bring that forward? So I'm really excited to see what people come up with. Next slide, please. Okay, so there's further updates to follow. We are literally at the beginning of this journey, but I do feel very positive about it. And I know that a lot of my team leads have come to me and they do feel that it's really positive and they enjoyed that kickoff session, learning about each other and particularly in listening. So it was a great session, and thank you so much to you both.
Thank you, and thank you for coming and presenting. I'm not sure if there needs to be any questions, but if there are, please put them in the box. So well done on the intro, and well done for committing to the training as well. I'm sure we're going to hear more from you in our future report outs. So it'd be really great to hear out of your 6 themes with 3 things each, 18 things to change, how that's moving along in the next few months. So
yeah, we're already sort of taking stuff forward. So I think it's already got that impetus, which is great to see.
Fantastic. And thanks, Neil, and thank you for your team for such a great reception. So I'm going to move, if people want to ask questions, please bung them in the box, but we're going to move quickly on to Matt, who's no stranger to report out, but this is your first time you've talked about CATA, Matt, I think.
Yeah, yes, it is. So I think it was a couple of years ago I was back at Report Out, so thank you for having me back.
That long? Is it that long?
Yeah,
Sorry,
yeah, it's been a while. It's been a while.
You haven't aged a bit, I would say, so
Oh,
great to see you.
Cameras,
and I'll let you have the floor.
Thank you. So yeah, I wanted to speak today about an ongoing project and the test of change we ran back in October, the methods of approach we took, so CATA, and apologies in advance for everyone, but there's going to be a lot of graphs. So if I can have the next slide, please. So the length of stay programme highlighted diagnostics specifically, as it was hypothesized that delays to imaging and mainly CT as well can result in an increased length of stay. So Richard set the ambitious target of how we can get to same-day scanning. I was brought in to look at this project for imaging around July. So now we had our challenge, we needed to understand our current conditions and how we move towards same-day scanning. So you can see in the top graph there's the main 4 diagnostic imaging modalities and percentage of patients that scanned within 24 hours. So internally with Kerry, we set our first goal of 85% of patients being imaged within 48 hours in all modalities. We then looked at demand in each modality, and you can see CT in the bottom left graph to understand what daily inpatient activity we needed to achieve. So Mike Hollow and the performance team told me that for best capacity planning, we should plan off about 85% of our highest demand. So in the case for CT, we need to do about 70 inpatient scans in a 24-hour period. And since May, our average requests have actually jumped up from around about 58 on a weekday to 64. So increase in demand, but not in capacity. And the narrative was pretty much true across all the modalities. We also looked at CT activity for April to June to identify if there's any gaps, and that's the bottom right graph. So East 1 was our main inpatient scanner, and work with the Quality Academy team about 2-3 years ago, we thought we should be hitting about 28 plus exams to get about 85% utilization. The data showed that we weren't achieving this now on a regular basis, and you can also see the dips in activity there, and that paints the picture for weekends where we're reduced to 1 scanner. So the next slide, please. So the planning stage, people first phrase, those who do the work improve the work. So we met with multiple stakeholders in imaging. We went through what each modality thought we could achieve with current capacity. We used the 5 why method, and Kerry used that a lot with me. And we completed a fishbone as well to better understand the barriers to inpatient flow throughout imaging and why we're not achieving that 48-hour target. So we identified the blockers, and then we started looking through in order what way we were going to tackle them. We had an 8-step, we got the storyboard, which is next to me still now, and a Gantt chart, which Kerry coached me through. And that was to track my progress. So every change we talked about with the teams, it came back to a conversation about porters, and each modality felt with more porters, they could achieve higher levels of daily activity and then utilize their capacity. So a bit of background on that: porters in imaging usually range from around about 16 to 20 porters. However, there have been numerous occasions where that drops below, and we've actually had radiographers or ICAs portering to assist with flow. And the latest being that was last Friday. But as taught, we should be driven by our data rather than just what people are saying. So we wanted to look into how porters affect overall activity, and if there was a relationship. That's where you get graphs like the bottom left one there, where we looked at our overall activity and then we added narrative to see and compare when we have difference in porters if we have a different output. The bottom right table then was put together with the modality leads, and that was what they could be doing and what activity they should be doing and what that actually meant for porter moves. And this helped us guide us towards that number of porters that we need. So the reason that porters were chosen as number 1 is the team felt it would have the biggest impact, and it linked to every plan we had. So we need additional porters if we gain additional capacity. If we move towards my dream of appointment-based system to reduce ward readiness issues and failed collections, we need that resource there to make sure patients are collected on time. So that was that, and it was time to act now, and this was the perfect week. So next slide, please. So as our porters are pooled in imaging, we decided to attempt a tester change which would impact the entirety of imaging rather than just CT. After lots of planning with the site services team, we had the perfect week. This was a test change where we had 24 porters, which in theory would maximise our activity. And given the figures from the modality leads, our aim was a 20% increase in activity. We also had 2 ICAs available for ward cannulation and ward readiness to help with CT and MRI, and we were hoping that would reduce failed collections, which normally sit about 10-15%. So you can see in the top graph, I had lofty aims. Did we hit them? I think in short, no. We had a 12% increase in activity throughout the week, but you can clearly see that the average is brought up by the record-breaking Thursday that we had. Without that Thursday, our average actually comes back down to about 142. But just to talk through some of the winners of that week, it was X-ray had a huge jump in activity. So they were averaging about 55 a day, and they had one of their most productive weeks. Ultrasound activity was fairly similar to a normal week. That is explained somewhat that the ultrasound staff tend to do a lot of porter moves themselves. I think we audited 1 month in August, they did 100 transfers. And CT, when you look at that data, had one really bad day, which there was a mix of lost capacity and some complicated patients, but then that was followed by a record-breaking 61 inpatients they scanned between 8 till 5. But again, that was due to some bonus capacity. So I think what we've got as an average there is realistic. So then moving on to failed collections, the bottom graph is our tasks on Symbiotics, which is the porter system, and the cancellation rate. So we had a 20% increase in the number of tasks, which is good. We put more tasks on, and we actually averaged about 10.9% cancellation rate. But unsurprisingly, the Wednesday where we performed the worst was actually our worst, with 15% failures. So it really painted the picture that although porters unlock the ability to get a loss of activity done, it is only one slice of the pie. Can I have the next slide, please? But ultimately, how did this affect the patients? So waiting times improved everywhere other than where I wanted them to, which was CT. So X-ray jumped to above 90% of patients being scanned within 24 hours, which is excellent. MRI had a great week and they stepped closer to that 85% within 48 hours. And ultrasound, it looked really good. They had a jump of 22%. However, this is linked to another improvement project we've done, which is we're no longer fasting patients, so we're able to bring them down straight away rather than having to wait those 4 hours plus. And that change was made in August and it's now embedded, which is why we saw a bigger impact in the autumn months. So CT actually had less patients in 24 hours, but 48 hours was unchanged. The bottom graph there is activity and waiting lists. So you can kind of see that start of the week, CT was in a really awful position, and that's why we didn't see that impact on waiting times. But ultrasound, X-ray especially, and MRI, we'd usually see that waiting list, grow throughout the week, but they maintained a really healthy position. I should also mention before I go on that we had feedback on the team on how their well-being was affected throughout the week. And the majority of staff felt their well-being improved or stayed the same, and they didn't feel extra pressure as an individual. They felt there was improvement flow, but the biggest barrier now, they were saying, was the capacity we actually have in imaging and ward readiness. Some really positive feedback that we saw, and a big safety aspect is the return to ward being dramatically lowered. And this was actually seen again in the Symbiotics data, as our average task time went down from 25 to 28 minutes to 21 minutes. I then presented all this data and the questionnaire feedback to the imaging team via our improvement board, and I sent the presentation to the site services team as well. Next slide, please. So we completed the PDS, now it was time for the A. It was clear that we increased our activity and some patients experienced reduced waiting times, but we didn't actually utilise the 24 porters we had. And I think this was the point where we needed to find that balance of what was a good porter number to what we needed. So it did show us as well that at peak times, we would actually overwhelm our current porter resource of 18. So we worked really closely with the site services team and we produced that top graph, which would utilise porters and match our average demand from that tested change week. But also we can see that it dips down in lunchtime, so it matches our activity. We're putting together a business case with site services now, looking to uplift porters for the additional, and that includes for additional capacity. So a quick segue onto additional capacity and what comes next on the work stream, which you can see at the bottom. Thanks to our rapidly reducing CT outpatient waiting list, from next Monday, there will be a second inpatient scanner 5 till 8. So that won't affect outpatient times. Now we're in a better position, and this is going to be business as usual. We're also, for the first 3 weeks of December, going to be opening an additional CT scanner at the weekends, and hoping that, dependent on how the training is going for the radiographers, that should be, again, business as usual in 2024. Alongside this, we've been running some different quality improvement projects. Well, one specifically with inpatient cardiacs. And this work happens because CT cardiacs wait a disproportionate amount of time compared to other angios. So Ross Thorpe's been leading that project, and he's set up a planned inpatient service, which has heralded some positive results. And we've got more actions to improve this and hope that that can be implemented in the new year. On Monday, we had a meeting with multiple ward managers and some ward clerks. And thank you to Kay, I'll quickly say, for organising that meeting. And now we've got some tests of change that we're hoping we can trial again in the coming new year. And finally, we have Symbiotics integration with SIA and Salus, which we're really hoping will improve communication and drive down that cancellation. And then the final one you can see on that work stream is just a new inpatient scanner, which is scheduled to go in March, and that's replacing our old lady scanner, which is 14 years old and deserves a retirement. And on to the final slide, please. So I just wanted to say a quick thank you to Lawrence, Louise and Ali in the site services team, because they really helped bring the perfect week together, and Kerry for coaching me through numerous cycles. I think on my storyboard there, we're up to 18 or 19, and also Kay for bringing me into the length of stay program and driving this one forward. And any questions, and apologies for all the graphs.
Never apologise for graphs, as far as I'm concerned. So well done. Great data. If there are any questions, either put your hand up or put one in the chat, please. I wasn't going to ask a question, Matt. I just want to say really, really well done, really well structured. But there probably is a question, which is, what was it like to be coached through a storyboard, and did it feel all right for you being on the receiving end of it?
I think the first time that Kerry coached me through it, I was probably a bit scattergun with my approach, and I think as Kerry's gone through it each time, it's come more streamlined, more natural, and then I think from that I feel we've got a better plan. So yeah, it has been good being coached rather than just me, going through it by myself and updating. So it's hugely beneficial, and that's maybe more thank you to Kerry than anything that I've done.
Yeah, and so well done to you and well done to Kerry. So there's some comments in there, so I can't quite read them fast enough. I do apologise. I just want to say that what you should have on this next slide would be a CAT certificate. So really, really well done. But we haven't put it in the pack, but it's going to come through. Oh, there you go. Ryan's put it in the chat. Your certificate is on its way to you. All right. So
thank you very
really,
much.
really well done. And I know Kerry is really close to a brown belt coaching certificate, which probably will come very soon. So really well done to everybody. And thanks for the massive care group support on the call as well. So you got some thanks and support from David there. Really well done, everybody. So next up is Burator and Thara. So Thara, over to you.
Hi, I'm working as a Band 6 in Burator ward. So just a little bit of introduction. We are a newly developed ward, just about to be 1 year now. So can you just go to the next slide, please? So a little bit of introduction about our ward. We are one of the 3 general medicines wards in Derriford Hospital. So we have got actually like nearly like 35 member of staff working over here, including the doctors as well as the other team members. And there are different levels of acuity actually, like level 1, level 1A and level 1B. So based on that one, we are actually working. So a little bit of information about our ward. 46% of our patients request complex discharge process, and 64% of the patients request like specialist opinion. And an average length of stay for the patients are like 11 days, and 2 patients get discharged approximately from our ward daily. And next slide, please. And regarding, as I have already told, like we are a newly developed ward. So initially we were struggling with not having a proper MDT meetings and like not having a structured meeting. So we came up with the targets and methods for solving those issues. So a couple of targets we have came up to is like improving the communication across all the staff members, including the doctors as well as the nurses, and focusing on the patient flow and reducing the patient discharge delays, and also to reduce the length of stay for the patients by 1.5 days, and through all these to achieve like a bit more like patient experience, to get a bit of more patient feedback. And there are a couple of quality improvement project methodology that we have implemented for this project has been displayed over there. Next slide, please. So what we have done so far is like for this project, we have actually gone through a process mapping. So we have completed this one with the MDT. We have actually identified some key issues and the reasons for the delays that's happening in the ward. And we have got the feedback from different team members like consultants, junior doctors, OT, PT, or like nurses. So actually we have listed all the problems and we have actually prioritized those problems based on which one we can actually focus on 3 problems initially. And we all came up with the interventions also, how we can solve these issues, and within what time frame these issues can be actually solved, and how we can implement those steps with all the care group members. So, and actually we have implemented also these problems into a fishbone method also, so that it will be more easier to display all these things. Next slide, please. So as an initial step, we for the daily MDT meeting, what we have done is we have focused on the daily MDT, like the ways to improve the communication, what we can do actually. And we have made a structured format for the MDT, which has been displayed below on the slide, like what to be actually asked during each MDT sessions, and one person to lead the team actually for asking the questions, rather than everybody talking in the MDT, one person to take the lead and conduct the MDT. And we have made it a more scripted way to all the staff groups. And even during the MDT sessions, we actually started making like CPL updates also on the same time, so that the communication is getting a bit more better and the delays are actually like prevented. Also like a recording of new actions and capture of patient delays, and all these things has been implemented actually. And what feedback we have actually got from all the team members is like we have actually improved the treatment and discharge plan for the patients, and we are also having better forward planning. So and also one more thing I want to highlight during this one is like when we started MDT in our ward, we were initially not updating the expected date of discharge for all the patients. So it was not up to 100%, but throughout these days, we implemented to update the expected date of discharge for all the patients. And now we are maintaining 100% in that one. Next slide, please. And as a second step, we have introduced a form in our ward that is actually shop list. So this has been implemented just to improve the way of communication between the doctors and nurses. And before implementing this form, we have actually had a couple of incidents where the escalation of the patients were getting delayed, and a couple of incidents happened that was actually preventable. So we came up with a plan like introducing this form can actually like highlight, like give a better handover from the night staff to the day day staff regarding like sick patients or the patients who who are getting discharged the next day, or like any other new admissions. So all these details will be filled on this form, and it will be handed over from the night staff, nurse in charge, to the consultants in the morning, so that they can go to the patients as a priority basis. They can review the patients initially, like those who request like an escalation, like if a patient is sick or like new score is high, they can actually go to this patient and review them, so that patient delay of discharge can be prevented, as well as if a patient requests ITU admission, that can be highlighted actually like a bit more easier way. And two more things what we have highlighted, what we have implemented is 2 consultants will be doing the ward rounds in the morning, and half of the ward will be divided like for each consultants, and the junior member of doctors will also be allocated with different patients. Like the board will be updated in the morning itself, which all patients are for allocated for which all junior doctors, thereby like they actually knows who have they been allocated with and what they have to do in the morning. So it's a bit more in a structured way actually now. Next slide, please. So this has actually not been implemented yet, but we are actually planning to implement the discharge protocol to make it a bit more easier way. So this form is about to be implemented in our ward. So this can be identifying the barrier for the discharge process actually, and we can actually prevent the delays in the discharge process by getting a bit more details on the expected date of discharges, and prepping the discharge patients. Like for example, if a patient is getting discharged, is planning to get discharged on Monday, and like a couple of days later, actually if the doctors are like if they are made aware, actually we can ask them to prepare the TTAs in advance rather than waiting till Monday. So thereby we can actually prevent the delays in the discharges, and we can also send the patients to discharge lounge, and the communication with the discharge team and community can be a bit more in a better way, and the priority list for the discharge task also can be highlighted. So as I've told already, by implementing this one, we are actually aiming to move discharges to earlier in the days, and preparing discharge drugs the day before discharge, and ensuring patients leave with everything they need. So in this way, we can actually prevent like a bit more like budget also, because sometimes what we have seen is like missing the patient's TTA medication. So if it has been prepared priorly, we can actually like prevent them by like querying to them, so that the budget also can be like reduced. So making sure that the doctors are doing the TTAs priorly, and making sure that the nurses are also like highlighting it to the doctors, so that proper communication should be maintained between them. Next slide, please. So what we have implemented as an improvement in our ward is like we have actually maintained a communication sheet in our ward. So during the initial days, what we have actually identified was there was no proper communication between the nurses to the next of kin, as well as the doctors with the next of kin. So what we have implemented now is like we have introduced this form and made sure that day 1, day 2, and date of discharge, the patient next of kin should be communicated and updated with all the details, as well as any case of med call or any other faults, we have to update the next of kin. And those who are updating to the next of kin has to complete the form properly, so that this is a record actually. And one more thing we have introduced is like the clipboard system. So rather than keeping the observation charts like blood sugar machine charts and fluid charts, food charts, we were priorly keeping it all in the nurse's notes. But now what we have done is we have kept it in a clipboard and next to the patient bedside, so that when the doctors are doing the rounds, rather than going and finding the nursing notes for the patients, they can actually review all the observations in the bedside itself. And we have just implemented this one like 2 weeks now. So actually we have got a really positive feedback from doctors, as well as other matrons from other wards also. So this one actually is like preventing from like a miscommunication or like delays in the record. So sometimes the staffs were actually like finding it hard to find the nurses notes, but now it's very easy to find, like do the ops and record it then and there itself on the patient bedside. As well as we have, based on the feedback from the doctors, we have actually implemented a couple of more computers to the doctor's room, and the management and escalation of the daily ward delays has also been improved. Next slide, please. And we are doing the team improvement huddle like on a weekly basis, like once in a week, like every Thursday at 3 p.m. This has been commenced on the 24th of October, and we are still doing that one. This actually helps us to support ongoing improvements and learning within the team. And we are also getting the team suggestions from different teams, actually, not only from the nurses, from the doctors, from the physio. Everybody is giving their own feedbacks, and we are actually continually getting improved with the daily team improvement huddle on a weekly basis. Thank you.
Sarah, that was an amazing presentation, by the way. Really professionally done and great information. So can I just put thanks back to you and your team, and to Roland and team, and to Ryan for supporting you, but really great impact.
Thank you. I would really would like to thank Ryan, because he was actually very supportive to throughout the MDT thing, like from the very first day till this date. Ryan was actually like very supportive, and all the team members, like consultants, all the other staff members, all the team members have massively supported me throughout this project.
Yeah, so well done. And I'm going to ask you one question. What's it felt like to make these changes for patients? How's it feel now on the ward?
So initially, it's not only like one person felt like we need an improvement. It was like the whole team actually felt like we need the improvement, actually, because as I've said already, there was no a structured format for the MDT to be conducted. So step by step, we have actually implemented that one, and everybody came up with a positive feedback rather than one person going back, nothing like that. Everybody came up like as a team, and everybody was working through that one. And actually, regarding the patient feedback also, initially we were having a couple of incidents where the patients were not happy with. All these things has been highlighted during the MDT, and we were taking steps to correct that one. So nowadays we are getting actually a positive feedback from the patient and the family members also.
So really well done, Sarah. I can't see any questions popping up, so I'm going to move on. But congratulations to you and your team. Really well done. And that was a very professional presentation. Fantastic.
Thank you. Thank you so much.
Next slide, please. So just a quick reminder to people, I think it's just under 4 weeks, the 14th of December. We've certainly got 2 practice coaches coming. No doubt it will get filled up because there's lots going on at the moment. So there's an awful lot of activity happening, both in surgery, in pharmacy, and lots of other places. So we expect it to be a bit of a bumper edition. So you're all welcome to attend, and we may get some more external visitors there. So I hope you've all enjoyed today's presentations. I did put in the chat, the one thing that joins them all together is the fact that patients will benefit them all, will get benefit out of all of them. So thank you very much, and we look forward to seeing you in the next report out. Well done, all the presenters.